Good afternoon, everybody, and welcome to our fourth and final virtual grand rounds on COVID-19 for the spring semester. We will be presenting and discussing the findings from the School of Public Health's 8 weeks of surveying New Yorkers. Our speakers today are our School of Public Health faculty, Dr. Nick Freudenberg, Dr. Vicky No, and Dr. Scott Ratson. I'm going to be opening our discussion today with an overview of the poll of New Yorkers, which was conducted on a weekly basis over the past 8 weeks. On the first slide, you will be able to see some of the methodology that we used, and our 8-week survey was weekly and asked questions about the medical, health, and economic impact of the epidemic. Our CUNY School of Public Health poll was conducted by Emerson College Polling, our partner in this endeavor, using a combination of landlines, mobile phones, and online panels. The sample for the New York City results each week was 1,000, with a credibility interval, a confidence interval, similar to the poll's margin of error of plus or minus 3%. The data sets were weighted by gender, age, ethnicity, education, and region based on the 2018 one-year American Community Survey model. Over the course of the 8 weeks, Emerson pollsters collected data from 8,002 New York City residents. Each week, our team of School of Public Health faculty and staff, with Spencer Kimball of Emerson Polling, got together to review and finalize the survey questions for that particular week. Data was then collected, and then we met again to analyze, review, and publish the results. Our choice of questions were, number one, some questions that we wanted to follow weekly over the course of the poll. Some others were bi-weekly, and some others were added to reflect significant changes in policy or in changes related to services provided, etc. The first slide reflects on, the second slide reflects on the results related to perceived risk of COVID-19 infection over 8 weeks. And as you can see, the risk was highest in March 27th to 29. On week 1, 40% of the respondents considered themselves to be at risk or very high risk or very high risk to contract the infection. And as the epidemic flared in New York City, the perception increased, highest in March 27th to 29th, where almost 60% of the respondents perceived of themselves to be at high or very high risk. And as you can see in more recent weeks, that perception declined. In our most recent survey on week 8, May 1st, you can see that the perception of risk is still significantly high, but declined to 46%. The next slide looks specifically at New Yorkers' top trusted source of coronavirus information. And we gave the respondents choices of various sources of information as they were available. And as you can see, that 35% of our respondents in New York City considered Governor Andrew Cuomo's daily communications to be their most trusted source of information, followed by the CDC, the television news, the WHO, then the communications through the White House by President Trump at 8%. Social media, surprisingly, was only at 5% as a trusted source of information. And then the rest is negligible, including printed media. And obviously, people were not relying on family and friends as a source of information. The next slide here reviews whether respondents over the periods of the survey reported somebody sick at home with symptoms similar to those that were communicated as symptoms of the viral infection, fever and upper respiratory symptoms, difficulty breathing, and so on. And as you can see in week 3, 13% of our respondents actually said that there was somebody in their household with symptoms similar to those ascribed to the viral syndrome. By week 7, that number had increased to a reported 20% of respondents saying somebody in their household was sick. We expanded that survey a little bit and chose to ask them, now we go back to the previous one, please. We chose to ask them about their household cohort. So as you see, the respondents had, the 1,000 respondents had a cohort of 2,772 people at home. Of those, when we asked them one by one who was sick of these household members, they counted 480 people, and therefore actually by count, 17% of household members were reported sick by our respondents. The next slide shows whether people have been tested, and we were talking about the nasopharyngeal swab. And as you can see, by week 3, only 3% reported that they had been tested. And of those, 12% said that they had tested positive. By week 7, 13% responded that they had received the test, a significant increase, more than 4-fold, still lower than what we would anticipate under optimal circumstances. But as you can see, 24% of those that were tested reported being positive for the test. And so as you can see, although the testing increased, the percentage of those that were actually sick enough and were actually positive for the virus also increased. Interestingly, by week 7, we asked them whether they had been tested within the last few days or the last 2 weeks, and 75%, 40% in the last few days, and another 34% within the last 2 weeks said that they had only been recently tested, as opposed to a smaller percentage in the ensuing weeks. As you can see, the weekly polls are in some ways showing a progression, for example, in testing. On the other hand, showing a decreasing report of people sick at home. And we will continue, we'll space out the polling every 2 weeks in weeks 10, 12, 14, and 16. And we will continue to monitor these health-related criteria. Now, I have the pleasure of introducing to you my dear colleague and friend, Dr. Nick Freudenberg, who is a distinguished professor of community health and social sciences and the director of the CUNY Institute for Urban Food Policy, housed in the CUNY Graduate School of Public Health and Health Policy. His research examines the impact of food and social policies on urban food environments and health inequalities. Professor Freudenberg is also founder and director of Healthy CUNY, a university-wide initiative to improve the health of CUNY's 275,000 students in order to support their academic success. He will be talking about the impact of the COVID epidemic on employment and economic issues, including food insecurity, healthcare, and education. And please, Nick, will you join me in this presentation and begin to share the results of that component of the poll.
Sure. Thank you, Ayman. And thank you all for joining us in this grand rounds. We're very interested to share our findings with you, and we hope to be in touch with some of you beyond this. So recent public health scholarship has focused on the central role that necessities of life, also known as social determinants of health, such as work, schooling, housing, access to healthcare, and food, play in shaping patterns of health and disease across communities and populations. And I think one of the most striking features of the COVID-19 epidemic in New York City is how quickly the pandemic has decimated people's access to the foundations of well-being. And in my talk this afternoon, I will use our surveys to show some of the ways that this has happened. I'll also show how COVID-19 and the responses to it have illuminated pre-existing inequities in New York City. And this emphasizes the high price that all New Yorkers are paying for allowing these inequities, among the highest of any city in the United States, to persist. And this sign that you see here illustrates a story that one of our partners, Bronx Health Reach, is conducting a survey of bodegas in the South Bronx. And they found, of the first 20 bodegas they contacted to find out how they were doing, 17 were closed. Just a feature of the really immense impact that the epidemic is having. Work is, of course, a central determinant of health. It provides the income people need for food and housing and everything else. And in week one, 39% of our sample stayed home instead of going to work. And by week by week 8, which was just last week, 1 in 3 New Yorkers reported a job loss in their household. Really a very dramatic loss of employment. And as my colleague Vicki No will tell you soon, loss of jobs contributes to other problems like depression, anxiety, and food insecurity. And we also looked in this survey at experiences with schooling. As you know, New York City moved to online schooling in the first part of March. And these numbers, I think, are striking. For families whose someone in the household, one of the parents had a college degree, 67, 2/3 of them said things were going well with your children's online education. But for those where the parents had only a high school education or less than 40% said things were going well. And this is an illustration of how the response to COVID, people's ability to have the technology they need to participate in online education can widen the gaps in access to education. Housing and healthcare are also important determinants of health. And you can see here that in week 3, more than 1/4 of the households feared that they wouldn't be able to pay their rent. And of those, almost 3 in 5 said that they were afraid that they might be evicted if they couldn't pay their rent. Fortunately, New York State has set up some protection for people being evicted, but we'll have to see how they play out. A disturbing finding is that 13% of the households said that someone in their household had lost health insurance. And again, one of the disturbing findings is that COVID-19 has been much more effective than President Trump and the Republicans in undermining the Affordable Care Act. We've really lost some of the progress that New York City and state have made in providing people with health insurance. And that will be a very important policy issue to pay attention to. In week 2, 4 out of 5 families said the epidemic had reduced their ability to get the food they need. And by week 8, as I said just last week, 44% of the households said that they were worried that their food would run out because of insufficient money. And 30% said that they had actually run out. These 2 questions come from the USDA Food Insecurity Screen. And what they show is that the level of food insecurity in New York City has doubled or tripled, depending on which of these questions you use, since 2019. Again, a really alarming statistic. One surprising finding, not shown here on the slide, is that 50% of the households said that they thought their households, that their diet of their household was healthier since COVID than before, probably because they were eating at home and not going out to restaurants and fast foods. There was a recent study in JAMA that 44% of the first 5,700 COVID patients in New York City were obese or overweight. Again, a striking finding. And again, an indication that allowing high rates of obesity and overweight to continue in New York City, to not address the underlying problems of our food system, has made the impact of COVID much worse. And we can see the epidemic has taken what was already an inequitable city and made it more inequitable. Among Latinx populations, 65% reported some level of food insecurity, compared to 44% in New York City as a whole. And 45% of Latinx reported job loss, compared to only a third of the white populations. Our surveys overall showed that low-income African-American and Latinx populations were experiencing a disproportionate burden, and we are particularly alarmed by the high rates of problems among New York City's Latino populations. You also see by household income the different rates of household. The silver lining of this epidemic is that it provides city and state officials, community organizations, and ordinary residents, parents, taxpayers, voters, and CUNY students and faculty with the opportunity to insist that there should be no going back. If a return to normalcy after we've controlled this epidemic is to go back to return to a more inequitable city, then the public health community will have lost an opportunity to write the next chapter of New York City's successes in overcoming our great public health challenges. And the last thing I wanted to say is some stories of success. Several new programs have been launched by the city and the state, and we see that most of these new relief programs have gone to the lower portion of the income spectrum. 53% of the households earning less than $50,000 a year got benefits, compared to 36% in the middle and only 10% in the higher income. And we also see that a number of new food programs have been established through the school food program, through emergency food programs, and through SNAP. And each of those are reaching a significant portion of the population experiencing food insecurity. But we'll need to pay attention that those programs are in fact reaching the most vulnerable population. Thank you very much for giving me the opportunity to share some of our findings.
Thank you, Nick. There were a couple of things in your presentations that were striking. One of which was the fact that women seem to have lost jobs almost twice as frequently as men. And I wanted you to comment on that. And the other striking feature was that, even middle-income populations received a significant amount of support. Can you comment on these two things? And then I have an additional couple of questions for you.
Yes, I think the probable explanation for women having higher job losses than men is that women are working in the most vulnerable and precarious sectors of our economy, in health and human services, in retail, in food services. And these are the sectors most decimated. These are also the sectors that have the fewest job protections and the lowest wages. So I think we need to pay very close attention to the burden. The other thing, and I think this is a measure both of the depth of the problems that the COVID epidemic has caused and the economic dislocations it has caused, is that while low-income communities of color have experienced the highest burden, it's affected almost everyone. And I think the fact that we see even middle-class families getting relief shows how persistent the problems have been. And I also think it indicates our shortcomings in establishing stable employment, stable access to healthcare, and stable access to food, even during a crisis. I think we faced similar crises in the city in the 2008 financial crisis. And shame on us that we didn't develop more sustainable solutions to the inequities that crisis caused us, that we could fall back on now when we're facing another such crisis.
I couldn't agree with you more. And Lois, who is one of our participants, was asking, did the loss of childcare impact the working women? And there's no question that not just loss of childcare, but also closure of schools may have placed a greater burden on the mother in the family, and especially single mothers. And I agree with your comment. Erica also was asking about the cohort, and there are 1,000 New Yorkers polled every week for 8 weeks, Erica, and details will be available later on. We are recording this session, and you can go back to these details. But going back to Nick with another question, which really relates to, we talk about the profound influence of social determinants of health in the patterns of health and disease in communities and in cities. And what are your thoughts? What do you think COVID is teaching us about the role of city government in addressing these determinants? You have alluded to that, but can you tell us more about during this crisis, in order not to create an opportunity for disparities to further increase and potentially to make the return to normalcy under more equitable conditions more likely? Nick, what are your thoughts on that?
Well, I think city government is really on the front lines of ensuring access to the necessities of life: food, healthcare, education. And mayors and city councils play a really important role. And we should judge them in part on their effectiveness of responding to crises like this. On the food side, which I've been monitoring closely, I think the city government has made a really concerted and, at least in the initial phases, effective effort to respond quickly. For example, the school food system is now providing packaged food in front of 440 of 1,000 schools in New York City. And each day, 450,000 New Yorkers are getting food from in front of their schools. Half of that food is eaten by children, and the other half by other family members and other community residents. That's a very imaginative and innovative use of a capacity the city already has. I think I also have to say, from watching this epidemic unfold, for city government to be effective, it has to be supported by state government and national government. And I've been disturbed, especially at the national level, by the failure of the national government to provide mayors, city councils, counties with the resources they need and the support they need to address what are really national and global problems. And we need to look carefully at our governance mechanism so that there's a shared responsibility and not passing the buck down when a problem like this emerges.
Couldn't agree with you more. And in your presentation, obviously there is this striking effect of the epidemic, a very profound impact on food insecurity in New York City, seemingly, as you mentioned, tripling the rate in just a few months. I'm trying to wrap my head around this statistic, and can you help me understand better what these numbers mean?
Yes, the most basic predictor of food insecurity is poverty, not having enough money to buy the food you need. And so many people losing jobs, you know, in the country as a whole, 30, 31, 32 million people have lost their jobs since COVID. So many people simply don't have the money to buy food. And so we need to be looking at responses that address that reality. One way would be a significant increase of SNAP benefits. And there's a proposal in Congress to do just that. Putting more dollars on SNAP cards, SNAP is the food stamp program, is really a very effective way both to enable people to get food, but also to restore local economies. The USDA tells us that every dollar spent on SNAP generates $1.80 in economic benefits to the local community. So as we want to reopen New York, revitalize those shut down bodegas and supermarkets, we need to be putting money in people's pockets, and SNAP is a good way to do that, and we should encourage our congressional representatives and our senators to expand SNAP in that way. We also need to be thinking about what is it about our food system that makes that left before COVID 1 million New Yorkers facing food insecurity, and how can we come up with more permanent solutions, such as, you know, a living wage for all people, such as increasing the ability of people to take time off from work, such as making healthy food more available both in institutions and in communities. So we have those of us who do food policy work, we have our work cut out for both responding to this epidemic and beyond.
Thank you. And Erica, I've seen your question. We will move ahead with our presentations, but I do promise you that the questions will be entertained at the end of our presentations. We will bring all the panelists to a wider discussion. At this moment, I would like to introduce our next speaker, my dear colleague, Dr. Vicky No, who is an associate professor of health policy and management and the director of the Center for Innovation in Mental Health. Vicky is also a clinical psychologist, and she has expertise in developing, evaluating, and implementing evidence-based treatments such as cognitive behavioral therapy for depression, anxiety, and trauma in diverse communities, both in the United States and globally. She has a large clinical trial in in Vietnam, looking at some of these treatments. And her research pays particular attention to understanding and promoting implementation strategies that can increase access and quality of evidence-based mental health services for ethnic minorities in general and underserved populations worldwide. Professor No will talk about the impact of the virus on mental health across race and ethnicity. Professor No, my pleasure to introduce you, and we are really interested to see the findings on mental health through our poll.
Thank you, Dean, for organizing this effort, and also to Nick for highlighting the pandemic and its impact on the social determinants and widening of pre-existing inequities. We'll talk a little bit more about that in my talk. So I just wanted to begin by telling you, we began tracking the mental health impacts in week 2, which, if you don't remember from the Dean's talk, started in March. Week 2 was March 20th, which was the weekend that New York became the epicenter of the coronavirus, and when non-essential businesses were ordered to, to keep their workforce at home, and when quarantine orders began. And so starting in week 2, we started asking about social connectedness. Later in week 3, we included screening questions on depression, anxiety, and which were tracked for 2 weeks in a row. And later every 2 weeks because we found consistent results. And then we also added some questions about hopelessness and fears and stressors and coping behaviors, which I'll talk later about. So the data I'm reporting here is just focused on New York City residents. So you can see here from this slide that, not surprising, the rates are really high. They started out, for social isolation, which is defined as not having any social connectedness. 22% of New Yorkers said they had no social connectedness starting in week 2, and then the quarantine orders began. Week 3 and beyond, we start seeing rates at, in the 40s, basically 43%, 40%, 43%. And then just this last week in week 8, it dropped to 35%. You see very similar pattern for anxiety. We started collecting that at week 3, and that is defined by a question on the GAD, which is the Generalized Anxiety Depression Scale. And we're asking, to what degree they feel anxious and on edge in the past 2 weeks. And this captures people who experience anxiety more than half of the time. And so starting in week 3, more than half of the time, 44% of New Yorkers are saying that they have this symptom. And this goes on, through week 6, and then in week 8, it starts to drop. Depression is about 10% point lower, 35% starting in week 3, and that has dropped to 24%. Both anxiety and depression are generally, you see this generally in the community at about 10 to 20%. So what we're seeing here is a doubling of that rate, or more, more than a doubling of that rate, actually. When we asked about people's feeling of hopefulness in the future, 60 to 62% said that they didn't feel hopeful. So, that's pretty alarming that more than half of our population is saying that they don't feel hopeful. I think this really speaks to just the degree of collective trauma the pandemic is having on all of us. And the American Psychiatric Association, they have this national hotline, and in that national hotline in the past couple months, they're finding that the rate of people calling in is 9 times the usual rate around this time of the year. So it's certainly, we're seeing really high rates in New York City, but it's also happening around the country as well. So in our next slide, we wanted to look at race differences because of the disparity that we're starting to see, the widening of disparity we're starting to see with other social determinants, given the disproportionate effects on minority communities. And we're seeing variable rates. As you can see here, this is for depression. Initially, the rates were higher for Latinos and Asians. Then they were kind of consistent across the board. And then over time, week 6 and week 8, what we're seeing is that there's a rise for Asian Americans, 41% in week 6 and then 34% in week 8. And, what this speaks to is some changes in some of the other social risk factors and the economic factors. Job loss is also increasing in the Asian community. It was highest in the Latino community initially, but in the Asian American community, it's catching up. The other thing that we're seeing in the Asian community is in week 5, we asked questions about discrimination and experience with racism and harassment. And Asians are also experiencing more of that, than all the other groups. So that's contributing to this. Okay. For anxiety, next slide. Okay, so for anxiety, we actually see lower rates for African Americans in that first week, and then week 4 and week 6 is pretty consistent across the groups. They're all very high. Then in week 8, where again, we see higher rates of anxiety for Asian Americans. Next slide. So these are the risk factors we're finding for mental health. It's not surprising. Perceived risk of infection is related. Having someone sick at home is related. Job loss is related, food insecurity, and being an essential worker. We see here that, you know, having someone sick at home is the factor that seems to be most predictive and most associated with mental health, both for anxiety and depression. So 53% of people who say that they have someone at home that is sick are experiencing anxiety, and 45% of those people are saying that they're experiencing depression symptoms. Okay. So we also asked New Yorkers directly what they thought was most distressing for them, what was contributing most to their mental health symptoms. And 44, nearly half of the respondents are saying that, you know, the concern about their family and loved ones is what's contributing to their distress. 30%, you know, getting sick, and the 14% of their family and loved ones getting, you know, potentially dying. Then the next rate is like 17% concerned about their own health, 12% getting sick, and the 5% dying. Then, you know, the next area is feeling unsafe, and then, you know, remaining isolated from home, losing their job, having enough to eat, losing their home. What I found surprising was that losing their job is actually fourth on this list, which really suggests that, you know, what people really care about is their health and their family, you know, their family's health, and then health. And that seems to be most important. What's also interesting about this is when you look at this across different race groups, all race groups have the same pattern except for Asian Americans. For Asian Americans, the thing that contributes most to their distress is feeling unsafe. That is what is highest. The next is having concern about their family and loved ones. So I think this really speaks to the degree of, you know, discrimination and harassment perhaps that they may be experiencing, given, you know, some of the racist things that we are seeing with the messaging about coronavirus. So, you know, this is impacting this community in this way. And I think this issue has been somewhat invisible, you know, or it hasn't been talked about as much in the media. Next. So we also asked New Yorkers about, you know, what they're doing to cope with this pandemic. And, you know, about over a third are engaging in healthy behaviors, and healthy behaviors include things like exercising, taking walks, engaging in self-care. So, you know, that's a good sign that they're doing that. Then the next, you know, strategy that's popular with New Yorkers is, you know, reaching out for social support, calling their family, loved ones, getting on Zoom, connecting with people from their church. People are also, you know, turning to the TV and going to the web, going on YouTube. Those are some of the things that people mentioned, and that's about, you know, a fifth of people said that's what they were using most. Another thing that, you know, was pretty high on this list was just following COVID guidelines. People seem to, you know, get some relief, you know, some feeling of assurance when they are engaging in things that they think will prevent them getting infected, like washing their hands, you know, staying inside, cleaning things. You know, what I think is a little alarming is that only about 8% are saying that they're not coping at all. They don't know what to do. But for the most part, you know, some of the strategies that are used are things that are very basic and things that I think we can do a much better job of promoting. The promotion of things like, you know, just reaching out and getting social support and, you know, teaching people healthy behaviors are things that are fairly basic that we can be integrating more and more in our public health communication. And so, you know, I think this is also something that really speaks to the degree to which we could potentially task shift some of the mental health supports so that we can activate more people to be promoters of these sorts of coping strategies. And I'll just end, you know, with that and see if there's any questions.
Thank you, Vicky. Please forgive me, I seem to have moved your department affiliation from Community Health and Social Sciences to Health Policy and Management. My mistake. I know exactly where you are. I did want to ask you some questions myself, and thank you for your presentation. I thought it was most interesting. What do you think we can do to respond to these high rates of mental health distress amongst the respondents, as you've shown us?
Yeah, I think, one of the things that, we're getting from this pandemic is the attention that, mental health is getting. And I think that's really important and can potentially be an opportunity for us to really raise awareness about mental health and how common it is. And I think given what we're seeing, a lot of self-care behavior can be promoted in a variety of different ways. It needs to probably be more promoted in the workforce, in work settings. It can be promoted in health settings. It can be promoted in school settings. And so, I think a strategy for us is really figuring out new models of care where we're integrating depression and anxiety, awareness and prevention in a variety of different settings, and engaging probably more in task shifting. I think this is something I've been supporting quite a bit for a number of years, and I'm seeing real value for that, because I think this is how we can really build resiliency and buffer some of the stress that this pandemic is generating for all of us. And and I'm sure will continue to, because there will be other pandemics and other wider community issues like this, and it'll be really important for us to equip more and more people with some basic tools that can promote well-being and positive mental health. So
definitely, I think this element of fear is an important one, and fear for those that we love, and trying to prevent ourselves from being a cause of infecting others around us may even prevent us from doing things that we may have done for ourselves. Even like going out, some people have really strictly stayed at home in fear of infecting others around them, especially vulnerable members of their family who are in the same household. And that puts a lot of stress. One of the things that I had seen in the results, and I would like you to comment on, was an interesting one where the elderly population seemed to show similar degrees of social isolation, if not slightly higher than the younger populations. But the older populations seem to not list social isolation as a major cause of anxiety or depression, while the younger people seem to consider this social isolation to be really causing them to be depressed or anxious. Can you tell us something about that? Is it something about younger people and their culture, or what is it?
Yeah, I think there's a couple things, right? One is that the seniors are, probably have been exposed to other traumatic events before. So just, the experience that they've had can probably, be somewhat protective for them, because they've dealt with things like this before. Sheltering in is not, potentially not the worst thing that they've experienced. Two is the, elderly community have been used to being more isolated. They've been isolated for some time now. And so they've probably developed more skills to, protect themselves against that. Whereas for the younger community, the social connectedness is really important. And the face-to-face interactions, the in-person interactions, because they're much more, that's how they're used to interacting. But in addition to that, this is probably the first time, in this generation, we've experienced something like this at this scale. So this is unprecedented, even for me, and I'm not in that age group, but, not having experienced anything where the entire community and the entire world is sheltering in, and where you see such high rates of death and hospitalization. And so I think for communities or age groups that have not experienced something like this, this can be very traumatic.
We got a question from the floor. Jonathan Block is asking, Professor Noah, what do you think can be done by governments or local communities to lessen the amount of harassment in Asian communities and help them feel more safe?
You know, I think first is just raising awareness about it, you know, and really combating the kind of discriminatory, racist rhetoric that, you know, we are seeing in the media by countering it. And then when it's witnessed, speaking out and, you know, and saying something, you know, I'm definitely seeing it more and more in my own personal circles as well. And so it's a very real thing. And, you know, people, I think it's also, you know, it's translating both in terms of, you know, verbal attacks and hostile interactions when people are out, but it's also probably affecting people's livelihood as well, in the sense that Asian businesses are also, you know, quite impacted, just as all others. But I think earlier on, you know, more people were, you know, not wanting to support Asian businesses. So,
yeah. Kathy also was asking us, what do they feel hopeless about in weeks 4 and 6? And that's an interesting question, Kathy. We had two different questions. The hopelessness questions were more about the here and now. And then we asked at some point whether they were hopeful about the future, the distant future. And the proportionality was reversed. I think people were feeling hopeless about the here and now. How can they get themselves out of this current predicament? Is there something that is going to happen that will change this? And people generally did not feel very hopeful that something could happen suddenly that would change their immediate predicament. And as far as the long-term hopefulness, many of the New Yorkers, actually 60%, said that they were hopeful about the future, meaning that we would recover from this and the future would look good again. But as far as now, people didn't seem to see a way out of it. And you know, I really cannot blame them. I just wanted also for you to tell us more, Vicky, about, could there have been preceding risks that were accentuated by the current stressors that really would be associated with depression and anxiety? I tend to believe that, yes, as you said, there is a doubling or sometimes tripling of these rates. Do you feel like there are underlying factors that potentially are associated with people transitioning more easily into this clinical manifestation of anxiety or depression?
yeah.
Do you have any?
Yeah.
Yes, ma'am.
I think this really speaks to, you know, all the things that Nick was saying are risk factors, right? The social determinants are things that, you know, we already know exacerbate mental health problems. You know, and when people's basic needs are not met, when they're not able to get food on the table, when they're worried about, you know, being able to pay rent the next month, and especially when they're worried that, you know, their family members can't get health care. And, you know, that was happening, you know, with COVID. So I think that these are some of the things that exacerbate, you know, the pre-existing disparities that we already knew existed, you know, in ethnic minority communities. So.
Thank you. And that could explain perhaps the differences in percentage across different racial and ethnic groups. Thank you, Vicky. This was very, very interesting. We will return with your questions. I'm receiving a lot of questions from the audience, some of which are cross-cutting questions where we would need for all the panelists to participate. So I think at this moment, I would like to present our final speaker, Dr. Scott Ratson, a distinguished lecturer in our Community Health and Social Sciences Department. This time I'm not going to make a mistake. And the editor-in-chief of the Journal of Health Communications, International Perspectives, which is housed at the CUNY School of Public Health. Dr. Ratson has 3 decades of pioneering accomplishments domestically and globally in health communications, health literacy, and strategic diplomacy. He is an expert in vaccine communication and has published a series of articles related to vaccine communication in the Washington Post, the Financial Times, JAMA, the Lancet, and he will talk about what our survey has found about New Yorkers and their attitudes towards vaccines for the COVID-19. Scott, I'm very, very happy that you could join us today, and you have the floor.
Thank you, Dean, and let me thank Professor Freudenberg and also not only for the presentations that illuminated their areas of interest, but weekly we've had a team that's been getting together on thinking about survey design and issues that would be important for us to know as both public health practitioners and also for the public at large. So I think we've had some very interesting findings. I'd like to thank the Dean at the outset for some that he showed on testing and knowing how many people might be sick at home. But one area that's of greatest interest, not only for us at this stage of the epidemic, but also in terms of the advances that we've had in public health, deals with vaccination. If we go to the next slide, please. I'm just going to read 4 quotes from the last few weeks. Dr. Anthony Fauci, who's been tested as the most trustworthy person in the federal government, who has said, ultimately, the showstopper will obviously be a vaccine, referring to the way to get out of this epidemic in the United States. David Navarro, who did grand rounds for us 3 weeks ago, and when we spoke there, he just followed an interview on Meet the Press, reminded, we are not so sure as it will come in waves, this COVID-19, in the way that influenza does. We think it's going to be a virus that stalks the human race for quite a long time to come until we can all have a vaccine that will protect us. And then I happened to do an interview in the Associated Press that the New York Post picked up, which said only a coronavirus vaccine can truly protect us from future outbreaks. But what if the effort succeeds and large numbers of people decide not to vaccinate? So again, science and the bench to the bedside or to the community is a big issue. And then finally, just earlier this week, the former CDC director, Tom Frieden, was quoted in a New York Times article saying, this is here to stay in all likelihood until we have a vaccine. And a vaccine could be a year or 2 away, or it could be never. So when we think about what we ought to do, as we go to the next slide, we're trying to figure out how this might even make it to market. And I remind people, where I think Dr. Frieden was right, is that we don't have vaccines for many viral diseases, notably HIV. It's been over 3 decades, it's been elusive. Other coronavirus vaccines, whether for SARS or MERS, Middle East Respiratory Syndrome, have not made it to market. So we have a lot of new areas under vaccine development. And as you might have heard, many companies in the United States and globally are working on this, both small to large. And some of these vaccines, of the 123 in development, we've not had an RNA vaccine that's made it to market for humans. We haven't had some of these yet. So they're new, they're innovative, and we're hopeful. But the current status, I would say, while we have some that just began testing here in the United States in the last week, we probably are likely a year at best away from actually having any potential scale up at the levels that would be necessary here in the United States or other key countries. So if we go to the next slide, it really now drives what our survey was looking at. We wanted to see if there were a coronavirus vaccine available, would you take it? And what's most interesting and frankly most frightening is this mirrors some other national data that roughly 60%, or as you see from week 3, when we thought the perceived risk was higher, which it was, to week 7, we still have just around 60% of the population that's willing to take a vaccine. And if we ask the question, if there were a vaccine for your child, for those who had kids in their household, it was even lower. So we're trying to figure out why. We had some open-ended questions, which we can't go into today with the interest of time, but we did try to put this together amongst other questions and the cross-tabulations with the rich data that we had from over 8,000 subjects over the 8-week period. And first, socio-demographically on the left, younger respondents are more likely to get the vaccine. There seems to be more trust, if I can say, in maybe science in the system, but not necessarily that alone. Higher acceptance is amongst Asian and white respondents, and we actually reported that out, as there are disparities, as there are with other pieces, for a variety of reasons that also were identified in the open-ended questions and some of the other ways that we've been looking at the data. And then finally, there's a higher acceptance among respondents with a college degree. And this also mirrors just national data, whether it be on the HPV vaccine or other vaccinations amongst the population. The perceived risk that people who believe they're at higher risk of illness were more willing to get vaccinated. And that's another component that one might expect. And then finally, acceptance of other vaccines. And this is also quite troubling because, as Dr. Redstone has already said at the CDC, that we need to work on seasonal flu vaccine this fall to be able to prevent other waves for a variety of reasons. Still, less than 45% of New Yorkers got the flu vaccine last year, and 20% of them have never got the flu vaccine. Now, the vaccine recommendations have changed over time to go to a younger population, but nonetheless, this is also a challenge as we see that vaccines for a variety of reasons are being refused. So if we go to the next slide, this reminds us why people are refusing vaccines. We asked the question in the last week, would you get a vaccine for COVID basically now or after June 1st or whatever it might be, and Dean will show some other data on this later. But of the 12% who would not take it, we asked why. And this should be something that we all wake up to. One, I think politicians, government are rushing this vaccine too much. We know from past experience of rushing vaccines in other parts of the world and even in the United States that this can be an issue if people don't think it's ready, despite the fact we have different parts of this current federal government that Nick referred to earlier of disparate messages, sometimes in the same day from the same task force. Two, people are worried about vaccine side effects. Vaccine side effects could be real. Also, there could be other ones, whether they want to call them psychogenic or sociogenic or not at all, but nonetheless, they're a concern for a population. Have a very low risk of getting disease. People have said, if I'm in the age group, why should I get that? That's a concern as well. I needed more information. That's a positive sign for us. The information will help people decide. My church or faith opposes vaccination. This does not seem to be evident if you look at the faith-based leaders throughout not only the country, but most recently when we had the issue with measles vaccination amongst the Orthodox Jew community, the rabbis and others came out that was not the case on opposition, but nonetheless, a good quarter of the New York population that we sampled said that. And then finally, which should be another concern, is they don't trust pharmaceutical companies. And pharmaceutical companies are only one phase, as we know, of vaccines as it goes through a number of regulatory and safety hurdles as well. So if we say that and we see that there's a refusal, we look at that as an opportunity. And the next slide shows a little bit of another challenge. And I say a little bit because we only tested this 1 week, but we thought it was so striking that we should report on this, that if there were a vaccine that we could have next week and it was ready to be for a clinical trial, how many of you would volunteer for it? And as you see, 7 out of 10 said they would not volunteer for a trial. That's always a challenge. Clinical trials, people are not always marching up to the front lines, but nonetheless, we do believe that this will be important. And to get to the trust factor again, to have a successful vaccine, you need a successful clinical trial. And those of us in health communication know we also would like the clinical trials to be from people that we trust. So it should be the people that are most at risk right now, frontline health workers, other frontline workers in all sorts of industry who also should be first online, also should hopefully be in a clinical trial. So another challenge that we've identified from the survey. And we go to the final slide. This is my sort of penultimate, how we can get to a vaccine for coronavirus. And the coronavirus that we call COVID-19 is actually SARS-CoV-2. But I think we could have a protected world, but this is very similar to the other challenges that we face that Vicki identified well, of how do we get to a literacy? We need to, it's multi-pronged, it's a grassroots, not just a grass tops approach. We have to go to schools, communities, faith-based leaders, and so forth. And to create that vaccine literate world, we have to try to figure out how we can have vaccine protection at a level that has equal access, that has the equity and the social values that we all profess, and hopefully will get us to the next normal for, you know, what some people might have called Generation C. Those of us will have to live with this new normal with COVID-19. So I'm going to stop there. The final piece I would just say is, you notice I use the term community immunity. I don't use the term herd immunity. Well, herd immunity is almost 100 years old. That's sometimes a policy, public health wonk term that people don't understand. If we talk about community protection, we all would like to have police. We'd all like to have clean water. We'd also like to have fire departments. We should think of vaccines and public health with the same energy and emphasis and investment. And that includes how we vaccinate and how we treat our people and have access to food and all the other pieces that we try to uncover during the survey. So Dean, I'll turn it back over to you, and if any questions at this juncture.
Thank you, thank you. Scott, we are seeing a lot of changes around us. And I must admit that the coronavirus fueled resurgence of the anti-vaccination movement. And there seems to be an overlap between opening communities, going back to business as usual, and this anti-vax messaging. And I wanted to know from you, how should health communicators address this, this new phase of anti-vaccination propaganda?
Well, thank you, Dean, and thank you for appropriately calling it anti-vaccine propaganda. It is not evidence-based that we should have an anti-vaccination movement that has legitimacy that other movements that have worked for social justice have. And part of that has to do with how this is even covered. When we talk about leaders of the anti-vaccination movement, similarly to, as frankly the president said of protesters in Charlottesville, there are good people on both sides. There are not two sides to the anti-vaccine reality. There's vaccines that are good for the public and good for individuals and good for society. And then there's this anti-vax movement that has an ideology that unfortunately has latched on to some small pieces of data that they've been able to draw out of proportion through sometimes, well, most times unsubstantiated studies and surveys and experiences. We often say in public health, of course, the plural of anecdote is not data. But these people, in fact, in the last couple of weeks, the anti-vax people have already latched on to this coronavirus vaccine that could save us to already beginning to demonize. Unfortunately, those of us in health communication and the media and the field don't have the same resources nor the same, celebrity status that the #1 tennis player in the world might have to say why he wouldn't get vaccinated, or some of these celebrities that believe that they have the wrongful link with autism and measles vaccines. So I think we have to be strategic, we have to be systematic, we have to use data, but we also have to address the emotions as real and how we can begin to demonstrate to people that this is a true hazard to society if we do not vaccinate for the solidarity and public health that we need.
So Scott, we got a question from one of our dear colleagues. Dennis Nash is asking, Scott, I was wondering if some people were more likely than others to say they would enroll in a vaccine clinical trial if a vaccine were available. And do you have an answer for that? We have an opportunity to go back and analyze this data by ethnicity and age and otherwise, but would you have some suggestions to respond to?
Well, and thank Professor Nash for raising those, and clearly his household survey and others that go into more depth will have a better understanding of this. At this juncture, it was week 7. It was a height of the hospitalizations in New York and other pieces. So we thought it would just be interesting to ask. unfortunately, what we found, frankly, was the same kind of wide disparities that you might expect. And unfortunately, some of it's from past experience with African American communities and the Tuskegee and from the syphilis trials and other disparities that we've seen in different parts of the world that have been brought up both through full length motion pictures to books in this area. So unfortunately, Dennis, right now I can't tell you off the top of my head how it breaks, but it did show that there was a breakdown on both perception of risk and ethnicity and racial background that was a concern to us. I think there's much more that we need to look into. And these are the kind of things to understand with qualitative research that often, doesn't suit well in a survey, a weekly survey.
So I did get a question from the audience, and I will answer that question under your supervision, Scott. So if you think I've missed a step, please tell me what you think. But the question was, if we get the vaccine by the end of this year, or maybe earlier, how long would it take to flatten the curve of the virus? And this is a complicated question because it has biological determinants attached to it. I think, first of all, it depends on how many people get the vaccine and how quickly they get the vaccine. It also depends on the degree of efficacy of the vaccine in protecting people, whether it reduces or eliminates the infection completely, but also the season where the vaccine is going to be available. But there are many illnesses that were almost close to aborted very quickly by massive vaccination campaigns. We cannot forget the polio virus vaccine. Now, it is plausible with 120 different vaccines being in development that the one that will be available first may not be the most potent one. And we have seen with other illnesses, including polio, with one vaccine being produced, then another one being injectable and the other being oral, and also in other vaccines, such as the one for pneumococcal pneumonia, and now for varicella zoster vaccine, that the optimal, most powerful vaccine may not be the one that is available initially. And as such, the initial vaccine that is available may and may not completely eliminate the propagation of the virus, but definitely will reduce it in a very significant way. Scott, you can correct me if you think I said something that you don't agree with.
No, I think the Dean and immunologist is great background, and I totally agree with you. And let me say that I think the bigger challenge will be, can we manufacture enough vaccine, and can we get 200 million Americans vaccinated in a speedy way? I don't think we have a good history of doing that. I don't think we have the vaccine capacity in the United States to do that. So I'm really quite concerned if we're banking on that as the answer. So we have to have both plan Bs in place, but we also have to have realistic expectations, as you're suggesting, of whether type of antigen, oral, or whatever type of vaccine does make it to market eventually.
Well, I'll tell you, Scott, you stimulated so many questions, I can't keep track. So I will give you one last one,
okay,
and make it brief, because
sure.
We will then open the entire panel. What are faith institutions focused on outreach able to do to help communities overcome these traumas through community outreach using self-resilience lenses? And that was referring to some of your comments on certain communities being less likely to have confidence or trust.
Well, thank you. And this is hopefully one others, such as Professor No could to describe later. One of the items we were going to have actually before the whole COVID epidemic came was a grand rounds, an event at CUNY to actually look at the vaccine refusal. And we had invited the Orthodox community and some of the nurses that have come together to have some very, very strong, excellent responses to show the value of vaccination and how it was not against the doctrine and so forth. But I would say that it's not only the religious leaders at the time outside in the community, but we can move. Vaccinations are not just in health facilities. 20 years ago, we couldn't get them at the CVS or the Rite Aid or Duane Reade or whatever. We had to make some legal and regulatory changes so pharmacists can even give vaccines. There's no reason we can't do more based in schools with the school nurses. There's no reason we can't do this in the workplace. And there's no reason we can't stop faith-based institutions and others also to show the values that they have for vaccination. This is too important to just let be to the health sector alone, if I can say that as a public health physician. We are all in this together, and we have to figure out ways that we all can spread the doctrine, if I say that positively, for better health and well-being with the cornerstone that we've had for 3 centuries now of vaccinating our children and adults. So hopefully that will trickle down and trickle up through our efforts here at CUNY and the illumination that you've been able to put on this effort, Dean.
Thank you so much, Scott. And before we turn to the entire panel for questions, I wanted to give you a few final slides that could be of interest to you. And the first slide I wanted to show you was a question that we asked as we were exploring returning to work and returning to normalcy. 25% of our respondents in week 7 were essential workers. So a very significant component of our respondents were still going to work in essential functions. But very interestingly, we wanted also to know what issues could be described as obstacles for people returning to work. And as you can see in red, besides the 25 that are essential workers, of those that were not, there's 26% of respondents that said, I will go to work under any circumstance. Fearless souls that did not see any reason to restrict themselves from returning to the workplace. On the other hand, we had 21% of our respondents that said, I will not go to work because I fear getting sick or bringing the virus back to my family. 8% said, I will not go to work because I have to stay home to take care of my child, which was an answer to one of the questions I received earlier from the audience. 21% said, I will not go to work until I have a test for COVID-19. And that's a very important element that most workplaces are considering in terms of what will there be for our workforce in terms of assessing the safety of the workplace and not becoming a place where the infection is propagated. And of course, we have a percent of 24% that were unemployed at that time and could not respond to the question. I wanted to share with you a final slide, which is an interesting slide where we asked people about a variety of activities that they would engage in if they were available June 1st. And when we asked about a routine doctor's visit, 65% said, yes, I would go right away. But we didn't show you that information, but in previous polls, we had asked people how many of them had routine doctor's visits that had been canceled because of the COVID. And this question was asked in several weeks, I think week 4 and week 6 perhaps, and there was 36 to 38% of respondents said that their routine health visits had been canceled. So it's no surprise that 65% of the respondents said that they would go to the doctor June 1st if made available to them. The green column represents a variety of responses that stated dates between August 1st and the end of December of when they would feel more comfortable returning to that activity. And the orange or mustard colored segment is when people said, I would not go back to that unless a vaccine was made available to me. And in the case of a doctor's visit, 7% only said that they would not go back to the doctor unless a vaccine was available. Now you see, when you go back to the beach or the park, an outdoor activity, if available June 1st, 48% would do it. A hair appointment, apparently much more important than I would have thought. 46% said that they would go to the hairdresser, and only 12% said that they would only go to the hairdresser or the hair salon if a vaccine was available. Now, when you look at gym, and difference between gym and going to the park is very significant. 48% of the respondents said they'd go out and exercise out in the open or go to the beach, but only 31% felt they would be safe or comfortable going back to the gym. 49% of respondents said sometime between August 1st and the end of December, but a significant 20% said, I would not go back to the gym unless a vaccine was available. When you look at restaurants, 31% were similar to the gym. When you look at theater, only 23% would be comfortable going to the theater at the current moment, and 29% said that they would not go back to the theater unless there was a vaccine. And interestingly enough, when asked about large outdoor events, 16% only said they would go out to a large event with more than 500 people, although it was outdoors, compared to 53% that would delay that activity between August 1st and end of December, and 30% of the population said they were not willing or comfortable returning to an overcrowded outdoors activity unless a vaccine was available. We have learned so much from this poll, and we've only scratched the surface. There's so much information that we have gathered, and we hope to be able to share with you in the near future. I would like to acknowledge everybody that was engaged on this activity. Professor Dr. Scott Ratson, our dear Spencer Kimball from Emerson, who was in charge of the actual polling, and I must admit he was most collaborative and highly efficient. Nick Freudenberg, a hero to all of you and myself, Vicky No, Ken Rabin, who is a distinguished scholar in our school and a wonderful resource to us, Barbara Aaron, head of our communications team, Lauren Rao and Sylvia Somariva, who were both excellent graduate students who carried us on their shoulders, and John Kalish, who was superb at producing the visuals that we are able to use today. And without further ado, I would like to use the last 15 minutes to try to respond ourselves, not just me. So I hope none of the panelists have themselves on mute. Wanted to, Erica says a hair salon is equal to self-care. I couldn't agree with you more, although I found the idea of having another family member cut my hair to be also a way of consolidating relationships at home and something fun to do. Vince McGee asked, isn't there danger in so many vaccine efforts and their publicity that people will relax other behavioral efforts, making staying at home and distancing, become disillusioned about the vaccine and the costs? So what is this background noise about so many vaccines being in preparation going to impact on people's behavior? I guess Scott can answer that question.
Well, I think it's something that we need to be concerned about, right? When we get different messages, whether it's from CDC, whether it's from companies that have no vaccines in the market, but they're saying they're going to be able to do this. There are some somebody even referred to some of this as infomercials now, if anybody's saying this is the one that's going to make it. So this is why we do need better and engage public health professionals and others in the whole chain, if I could say that. But, this is something for discussion and something I think we ought to all, realize that we don't have public health centralized in this country, and it's very much should be community driven, and we need to give the evidence. And that's why we say give the vaccine literacy of what to expect if it makes it and what to expect if it doesn't, but not to forget, seasonal flu this fall.
And then can I say something about vaccination here? I'm, as any public health professional is, an ardent supporter of vaccinations. They've saved, millions of lives around the world. But that number that you showed, Scott, of 55% of the population mistrusting the pharmaceutical industry, that isn't always misinformation. It's based on their experiences. We have to look at Purdue. We have to look at, the mishandling of the HPV vaccine in Texas by Merck. And I think the epidemic is raising some deeper questions about, does it make sense to leave this responsibility in the market, in the pharmaceutical market, an industry that has been very profit-driven, not health-oriented? And should we be thinking, as other countries have, of having a much more public responsibility for the development and testing of vaccines as a way to address that deep and often founded mistrust of the pharmaceutical industry? Would that help to address the substance of that mistrust, which mistrust in the public health community is a toxic, really dangerous, and anything we can do to reduce it will be important.
Oh,
So true. I agree with Nick, and I just wanted him to remain on the screen for a minute because the next question was going to be addressed to him. But I really do think that this is an opportunity for us to remedy some of these long-standing anxieties, feuds, and mistrusts, because we're in this together, man, and the vaccine is going to be an important component. Ruth Finkelstein was asking, and I think, Nick, you might be the best person to answer that question. I was very struck by the high levels of food insecurity. While it is clear that the city's food czar is working hard, there remain so many different public systems delivering prepared meals, DAFTA meals, Meals on Wheels, Get Food New York, food hubs, etc. What can be done to expand access and eliminate redundancy?
Ruth, hi, very nice to see you virtually here, and thank you for your question. And I agree completely. On the one hand, there are some excellent new programs being developed, and I think Catherine Garcia, the emergency food czar in the mayor's office, has been doing a really good job in bringing together the advocates and the public officials and others to begin this coordination. But as someone who was also active in responding to the first stages of the HIV epidemic, I saw how challenging it was when dozens of organizations each created programs on their own and launched those programs, and there really isn't. Scott just said we don't have a centralized public health infrastructure. Well, this is a call to begin to develop that, and yes, it needs to come both from the bottom up and the top down. And around food in particular, I think there's a beginning recognition that our food system has been too anarchic on the one hand, too many players, and in the same way as the pharmaceutical story, too market driven. And what determines who gets food and who doesn't get food is market based by what's profitable and what's not profitable. And that driving force has contributed to leaving 1 million people in New York City before COVID food insecure, and to so quickly rising that number to almost 3 million. And so we need to be creating new mechanisms. Our institute has called for the development of a 10-year food plan for New York City with very clear metrics and an accountability in both government, but also in civil society, to make sure that we're making progress towards the goal of reducing food insecurity, reducing diet-related diseases, treating food workers better. And this epidemic is an opportunity for us to do that.
There are two questions that I will answer briefly. One is that Governor Cuomo mentioned in a press conference earlier that 60% of the new hospitalizations were folks who were staying at home. And it's interesting when we asked our respondents who were tested and tested positive where they thought they got the infection, 60% of them said, we think we got it at home. So staying at home is not a protective mechanism unless there is a protocol within the household of interaction. And it is not true that if one person is staying at home, that everybody is staying at home. There are many households with 5 people and more where a member of that household, for example, is going to work, and as such is likely to bring it back to the home. So we need to be aware of that. Another question was, it's so strange that people felt more comfortable with getting their information from Governor Cuomo than they did from the CDC. And I really cannot answer that question except to say that perhaps having a face behind the information that's being disseminated personalizes that experience and perhaps increases the chance of feeling comfortable and trusting of the information. One question to Vicky, if you're still there, please, was a question about the Great Depression, and that people that lived through that experience never fully recovered and had certain behaviors, consumer behaviors, and certain attitudes, and perhaps a mental health framework that was residual and stayed with them for the rest of their lives. So Vicky, what do you think? Are we ever going to recover from this? And what should we do?
Yeah, you know, I definitely think there's going to be some long-term ramifications for what we're seeing here. You know, both because this is an ongoing chronic issue. It's not going to end at the end of this year. We'll still be social distancing for some time, I think. And you know, there's also been mentioned that there may be other pandemics that are just as contagious that will be in, you know, the future. And so, you know, I think that the fears are going to continue. And, you know, I think anxiety, you know, will continue to rise. You know, for what we need to do, I think, again, you know, just engaging more with all the trusted organizations that are already in people's lives, I think is the best way to promote better mental health so that we can buffer from a chronic stressor like this that will, you know, continue. So I think, you know, bringing in more opportunities to raise awareness, promoting very basic skills, you know, to teach people how to engage in better self-care, teaching people, you know, just very basic psychological techniques that are evidence-based, that can be taught and have been demonstrated to work internationally in low middle income countries, because they don't have mental health specialists there. We can start transferring some of that technology and that knowledge back to the US, because we'll need everybody to be mental health promoters, you know, and especially in places that are the highest risk. Like, so for right now, for example, the healthcare workers, that is a very difficult group that is, you know, that is going basically into a war zone on a daily basis. And so there needs to be probably more integration there so that they can, you know, they can do more just prevention, you know, to keep people from developing PTSD, for example. You know, we've seen recently that there was an ER doctor that committed suicide. And there's been other incidents like that where healthcare workers are just overwhelmed, stressed out, and frankly, just traumatized. And so, you know, I think there needs to be conversations in those settings to prevent that from, you know, happening, because they are our soldiers right now, and we need to make sure we take care of them.
Thank you, Vicky. We all need to take care of each other. That's the message you're giving us. And I submit myself to your care anytime. But before we close the panel today, I have to read a question by our Graduate Student Association, since they're my boss. And they said, please ask this question at the end to all speakers. Do you think this is an opportunity to rebuild green with sustainability and environmental health as a priority? Should we allow industries that are failing now, that are not good for the environment, e.g. fossil fuels and airlines, just to fail, to allow other industries that are good for the environment to succeed? I will admit that this requires an entire panel. My dear students, what a provocative questions. And I will say to some extent, yes, and I'm bewildered by where some of the government's public support is going. But at the same time, I think it is an opportunity for us to re-examine our priorities. As the Dean of the Public School of Public Health in New York City, I thank my panelists, I thank my audience, and I remind you all that as the Public School of Public Health, we serve the public. We are proud to be in New York, and we are proud to serve you. Thank you for participating in this grand round, and I promise you, we will return to you in the fall. This is recorded, and you can access it anytime on our website. Many thanks to my panelists and to the audience. A thank you, and have a good summer.
Thank you, Dean.
Thank you,
Thank you.
Dean. Thank you, everybody.
Thank you all.
Thank you, everyone.